So thanks very much. Welcome to Leicester. So you've heard a bit about sort of the history of SCAD, and you've seen Bex. And so Bex, if you like, for me at least in the world of understanding SCAD, is index case 1. Bex and I had a conversation, whenever it was, a long time ago, when she came in with her SCAD, and I said to her, you'll never meet another person who has SCAD. This is a very rare thing. We might never see one again. And I was trying to say, off you go. And she said to me that that's surprising because she already had a dozen Facebook friends. And why wasn't there any research into SCAD in the UK? And before long, she'd started to gather these. And also, here is kind of one of our inspirational international collaborators, who's Rajif Gulati, who with Sharon Hayes and Marissa Tweet works at the Mayo Clinic, and he also supported us early on to get started. And this is the first little gathering of kind of pre-Beat SCAD. And at this stage, I was like, okay, fair enough. It's not a kind of, it's not 1 in a million disease. There's a few other people out there, but it's still quite rare. And Bex just kept going and going, to the point at which we have to start asking ourselves, is this really a rare disease? And I think the answer to that question is, it's not as common as conventional heart attacks, but it isn't rare. I think between us, who are looking after SCAD patients now in the clinics in London, Leicester, and in Forth Valley Royal Hospital in Scotland, we're seeing probably more than 500 new patients with SCAD a year now. And I still suspect that we're not seeing everyone. I think that there are still little kind of patches in England, Wales, Northern Ireland, and Scotland where the patients are not still getting referred. So I think there's more out there. And then you start doing the maths and you start figuring out that this probably means there's 4 or 5 SCADs a day happening in the UK. So I think this is no longer a rare disease. And therefore, it's all the more important that we focus on trying to understand exactly what's going on and what we need to do about it. So some of these slides, those who have been to the conference before, you will have seen something similar before. But I think that we should go back to the beginning and say, what is SCAD? I think the first thing that's really important, and this is the kind of how I start when I'm talking to cardiologists, is to remind them that SCAD is a different disease. It's a different cause of heart attacks. And this is important because when I was in Yorkshire yesterday talking to some medics about SCAD, and I said to them, would you treat Alzheimer's disease patients with Parkinson's medications just because they both involve the brain? Of course you wouldn't. So why would you treat somebody who has SCAD in the same way as someone who has had a conventional heart attack, just because they both involve the heart? What happens in SCAD is that a bruise builds up in the wall of a coronary artery. And I sometimes remind people that we think of our arteries as a tube, but actually they have a chunky wall of muscle cells around them. And what happens is that the bruise in the wall of the artery pressurizes. And as it pressurizes, the pressure gets above our blood pressure and it starts to compress the artery from the outside within the wall of the artery. And as it does so, the place where the blood should be flowing starts to get smaller and smaller. And this is what happens in SCAD. Sometimes, particularly later on, the bruise can actually rupture, if you like, through the wall into the place where the blood should be flowing, and sometimes you can get free-flowing blood going from one side to another. But it's caused by this bruise or bleed. I don't like the word tear. Tears sound kind of permanent and rather frightening. Bruises are things that heal over time, and that's actually what happens with SCAD. If you leave it for long enough, it will heal and the artery will go back to normal. And that's why I use that term. So this is an example of some of the research that's been done. I mean, we use it as a visual image, but we also did a lot of work to understand how that process of the bruise developing works. So this was actually one of the researchers who took two-dimensional images, lots of slices, and put all of this together to make the whole image. And what you can see here is the red is where the blood should be flowing. And you can see the narrowing. It's at its most severe at the bottom end there. And the black is the bruise as it's tracking around in the wall of the artery and compressing it from the outside. So when you see your angiogram and you see the narrowing, you're not seeing the black stuff. It's in the wall of the artery. You sort of think of the narrowing, well, why is the narrowing there? It's because you're not seeing the wall and you're not seeing the thing that's compressing it. So yesterday in Yorkshire, I was talking a lot to an audience. It included quite a lot of ambulance crews. And I guess I was trying to encourage people to think about SCAD when they're approaching patients, because there will probably be some of you in the room who, when you presented, it was a delay. There was a delay. People didn't initially say, yes, you need to go. So I think it's getting better, but I think there is still a journey to go down. The symptoms in SCAD often are quite typical of heart attacks. It's just that you are not typical of heart attack patients. So the healthcare system is designed to look for, older, predominantly male, smoking, diabetic, high blood pressure type of patients. And SCAD patients don't fit that bill. And it's one of the things that Beat SCAD has been doing, we've been trying to do as well, is to get out there into the community of first responders, essentially, to say, you've got to think about this, because the critical thing is to take patients to hospital to get a troponin checked early on. Serious rhythm disturbances are uncommon. I think it's worth putting that in there. It does occasionally happen. We will get some patients who have had a cardiac arrest type of presentation, but it is not common. And this is particularly important when people worry about risk associated with recurrence, because the risk of recurrence and something like really frightening happening is actually very tiny. And again, that's a really important thing to keep in proportion. So the key to diagnosing SCAD is talking to the patient. That's probably the most important thing. And those of you who've been to a SCAD clinic, whether mine or somebody else's, will know that we spend quite a lot of time talking to you just to listen to hear the story of what happened to you, because that tells us an awful lot. The next thing will be heart traces from the ambulance crew and otherwise. Some of you will have heard the term STEMI. Do you have a STEMI or an end STEMI? That's all about this little bit here of the ECG and whether it goes up or it doesn't go up. It's ST elevation. It's that little segment that goes up, so just a small trivial detail there. The key really is measuring the troponin often. If there is ST elevation on the ECG, often people will go straight off to the cath lab for a diagnostic procedure and maybe further things if that's needed. But most SCAD patients present without ST elevation. And in these patients, it's all about measuring the troponin, because the ECG will often look normal. And again, this is something that we try and get out there. In terms of the diagnosis of SCAD, the angiogram is essentially still the key diagnostic tool. And sometimes the operators who are using the angiogram will take pictures from the inside of the artery to get a really clear picture of what's going on to make sure that the diagnosis is made. And there are particular angiographic features, which I won't go into detail with today, but we do a lot of work with our interventional cardiology colleagues to make sure that they recognize this. And this is what the inside of the artery looks like. And so this is perhaps a typical picture here, where you've got, this is the wall of the artery here, but actually the outer wall is out here, and between the outer wall and the inner wall is this thing that looks like almost like a half a moon-shaped thing. And this is the bruise in the wall of the artery in this particular patient that's squashing it down. This is the little fenestration that I mentioned, the little connection between the two bits that you can see here. And then there are important things such as here, where actually they've popped the wire and the imaging catheter in the false lumen, and that's really important for operators and things to recognise because of managing patients. Diagnosis can be tricky, and that may apply to some people in the room. I would say that around about 1 in 10 patients who gets referred to the clinical service doesn't have SCAD or doesn't have definite SCAD. And that's okay, because what we need to do is to make sure that, I sometimes say, we need to make sure you're on the right railway line. If you get the wrong diagnosis and you're heading off down the wrong tracks, then that's important because that affects your treatment strategy. So we will spend quite a lot of time thinking about that, and there will be some people, maybe some people in the room, or maybe some people who are watching online, whose diagnosis changes during that process. But that's the right thing to do, because it means that we're on the right tracks in terms of your management. There will also be some patients who, even after the angiogram and all of the imaging that's been done or the information that we gain, there is a degree of uncertainty. And again, that's okay. You don't need to be frightened about that because we manage the uncertainty into the treatment strategy. So sometimes we will cover bases. So we might say, well, we can't be absolutely certain this is SCAD. It could be something slightly different. And so we'll manage your treatment strategy to cover both things. But it's just important to understand if you come along to the clinic, and sometimes we'll register patients as a grey case because they're in this zone where there's more than one possible diagnosis. But don't worry about that because that's what we're factoring into the management plan. So is there a better way to diagnose this? And this is sort of nudging in the direction of research, and you'll hear some more about this in the afternoon. One of the problems with invasive angiograms, and again there may be one or two people in the audience to whom this applies, is that sometimes the process of getting the pictures can make the situation worse. Sometimes we get the catheters that we use to take the pictures can cause an injury to the artery during that process, and that's obviously a tricky thing, and people are trying to be careful, but we know that SCAD patients are quite vulnerable at the time of their angiograms. So it would be nice if we could diagnose SCAD without having to do that, given that for the most part we don't want to be putting stents in, things like that. Can we improve non-invasive imaging diagnosis using a scanner rather than the tubes that have to go inside the artery? Or can we develop a blood test or a urine test for SCAD? These things would be transformatory to the care of patients and are part of the plans for research. So the treatment of SCAD in that sort of immediate setting. What are the issues? Well, the first thing is, and this is one of the reasons that making the diagnosis is so important, and again, I think over this decade we've made a lot of progress in terms of cardiologists recognizing SCAD and getting the diagnosis right. The problem is that unlike conventional coronary artery disease, where you have the cholesterol deposits in the wall and inflammatory cells and so on, when you stretch a stent up inside the wall of a coronary artery, when there's a bruise in the wall, the bruise propagates. So it moves along inside the wall of the artery, and you can get problems with it. And this is one of the reasons why we get problems with stents. And you can see here the narrowing here, but then after the stent has been deployed, you can just see it here. You can see that the bruise has now moved upstream and caused a narrowing here. And sometimes this is necessary to stent, and I think that that is an important message. I'll come back to it in a little bit. So some of you will have stents, and that's not necessarily a bad thing. There are circumstances in which stents need to be used, but where we can avoid stents, we are trying to avoid them because of the problems that arise. A small number of patients will have bypass surgery. There were also challenges here. Because of the bruise in the wall of the artery, the surgeon's got to try and find the true lumen to put the graft onto, because you don't want to graft the false lumen because that's not a great thing. So it's not easy doing bypass surgery for patients who have SCAD. But sometimes in real emergency situations where there isn't an option, that is the route that we have to go down. And there will be a small number of patients who have had bypass surgery as an emergency setting, but it's not for most people, it's for a few cases. This is a real sign of, I think, progress. So hopefully you're getting your eye in now and you can see the long narrowing here in the artery coming straight down the page here. And on the other side, you can see the same artery over time with a follow-up angiogram. And you can see that it's now normalized. And I think the first thing to say is, I think when we started doing SCAD research and gathering SCAD patients, you'll probably find maybe 3/4 of patients with SCAD were being treated with stents. Because that, if you like, was the sort of the knee-jerk reaction of the interventional cardiologist, was to do what you do for all of your other heart attacks and bung in some stents. But over time, what we've learnt is that because the artery heals if you leave it alone, if we can manage it without stents, then that is often a good approach. And these days in the registry, something like 85% of patients are now being managed without stents. And that's a major shift in the practice over the course of time that we've been doing the research, and is a sign of real progress. So what's going on here? Why does it normalize? Well, it's because it comes back to my bruise word at the very beginning. Bruises heal, they reabsorb. And what we can see, and this is Rob Jackson's work, when you do follow-up imaging of the artery, is you can actually see little tiny vessels that go into the wall of the artery. They're sucking the bruise back out again, or they're helping to heal the bruise, and as they do that, the artery goes back to normal. Now, these days, we don't go back and do follow-up angiograms because we know that this process will happen. It's a really frequent question that I get asked in clinic is, has my SCAD healed? And the answer is yes, because it always heals. Back in the day, we used to take patients back and do the angiograms, some of which I've shown you here, which give us the nice pictures to be able to show you. We don't do that these days because we know the artery is healed and we want to minimize procedural risk. So the artery will heal. There's also it's important to distinguish between the artery and the heart muscle. So the heart muscle, if you like, is the heart attack bit. So you will get a little scar on the heart muscle as a consequence of the SCAD heart attack. Yeah? So it's the coronary narrowing that causes the injury to the heart muscle. The narrowing itself will heal, go back to normal, so the artery will go back to normal, but a little scar will be left where the injury occurred to the heart muscle. So again, sometimes people will ask me, for insurance purposes, do I have heart disease, do I have coronary disease? For insurance purposes, generally speaking, the answers to those things is yes and yes, because you want to make sure that your insurance is covering everything. So this is, again, an important message. So I've said to you that when stents are used, compared to conventional coronary artery disease, there is an increased risk of a complication. So we talked about iatrogenic dissection, where the catheter makes the dissection worse or causes a problem with the artery. And we also looked at hematoma extension, where the bruise tracks in the wall of the artery. These are the commonest problems. But it is important to understand that there are situations when stents are needed. So if your artery is blocked, if the artery has no flow in it, and the operator looks at that and feels that there's that's providing jeopardy to your heart, that you might have a bigger heart attack if it's left like that, the operator will pass a little wire, sometimes stretch with a balloon, and sometimes they will deploy a stent. And the reason that this is important is that sometimes if people go back to hospital having had SCAD, having some information, maybe having a recurrence event, for example, it's very important to trust the operators. They need to make the decisions based on what they see. So although, yes, we want to manage most SCAD conservatively, it may be that actually on that particular occasion, you need a stent, okay? And if that's what the operators think, they know about SCAD these days. We've been talking about it for long enough. So just go with what the operators say, because that's probably what you need in those circumstances. And that's what this shows, is that when operators make a decision to stent, what this is about blood flow. And it's showing you that when operators make a decision to stent, on the whole, they make things better. And that's because on the whole, the operators that are working in the UK are making the right choices. They're picking the right patients to do the procedures with the stents on. This is a nice little study, again, funded by Beat SCAD, supported by Beat SCAD, that showed that on the whole, the decision-making of operators in the UK is good when it comes to who to put stents in and who not to put stents in. So this, again, is Beat SCAD funded research, and this is good news for SCAD patients. And this is showing that the heart injuries after SCAD are small. There will always, unfortunately, be a small number of patients who have a bigger heart attack with SCAD, but they are much less common. Most heart attacks after SCAD cause small injuries to the heart. And this is relevant when we come to think about recurrence. We'll talk and think a little bit about recurrence and its frequency in a moment. But often I will say to people, look, yes, you have to accept that there's a small risk of recurrence after SCAD. And there will be some people in this room who have had recurrent SCAD. But one thing that's really important to remember is that the prognosis from SCAD is excellent. People with SCAD do well. And the reason they do is that on the whole, it causes these small injuries to the heart. And so even if you have recurrent SCAD, usually the combined injury to the heart is too small to be of significance to the performance of the heart as a whole. And that's an important message. So there will be a small number of people who will have a bigger heart attack, and it's those people that we will be concentrating on getting the tablets right and the medicines right to help the symptoms. But on the whole, the injuries to the heart tend to be on the smaller side. So recurrence is the elephant in the room, if you like, and we should just talk about it. We know that recurrences occur. I think the important messages are, first of all, it's not that common. Okay? Around 10% of patients with SCAD from the prospective studies will have a recurrence over 5 to 10 years, a 1 to 2% risk per year. So it's not a high risk. It's not the sort of risk that you want to stay at home and not live life for. You need to put it in that kind of perspective. So the risk of recurrence is not that high, but it is possible to have recurrent recurrences, and they do happen. But again, the cumulative damage to the heart tends to be not large enough to be causing problems with heart pump function. Occasionally it does, but not commonly. And this is the reason that the prognosis from SCAD is so good. But it's also a big focus for our research, because we want to come up with solutions that reduce the chances of recurrence happening or eliminate recurrence, because that's obviously a key target for what we're trying to achieve. What medications do I need? I'm really excited to be able to talk to you now in the era of clinical trials for SCAD. So up until now, most of our decision making has been made on the basis, if you like, of what we think is best. But we are starting to get to the point where we are seeing clinical trials. They are starting mainly focusing around the antiplatelet therapies in the first instance. That's your aspirin and aspirin-like drugs, to try and work out, what of those type of medications you should be taking or not. Treatment should be individualized. Different people are different. We've already heard that there will be some people who will have more injury to the heart muscle, and those patients on the whole will need more medications to support that. And then there'll be some patients who have essentially normal heart function who maybe need less medications from that perspective. The role of these antiplatelet medications in patients who don't have stents is not clear, and that's what the clinical trials are particularly focused on at the moment. It's worth talking about a few specific types of medications. So beta blockers. There is an observational study. It's a single observational study from Canada, which suggested that taking beta blockers and having good blood pressure control seemed to be associated with a lower risk of recurrence. And this is the basis of a lot of the treatment strategy that we adopt at the moment in terms of trying to see whether we can maintain a little bit of beta blocker in patients. Again, we have to understand that taking medications is always a balance between the benefits and the side effects of taking the treatment. Some people can't tolerate those medications, and that's okay. If you can't tolerate it, that's all right. But those beta blockers, they will lower your blood pressure a bit, they will lower your heart rate a little bit, and so some people can manage them, some people can't, but that's the reason that they're there. And then there are other medications. The ACE inhibitors, they end in pril, or the angiotensin receptor antagonists end in sartan. These are medications which lower blood pressure, but also support the heart. There's a whole bunch of medications now that support the heart if there's more injury. Statins. Well, we've just said at the very beginning that SCAD is a different disease. It's not caused by cholesterol. Having said that, there may be some people who have a very high cholesterol, and that if they were in the community anyway, not having had a SCAD heart attack, they would be recommended to be on a statin to reduce their lifetime risk. So there's an online risk calculator. You can Google it, QRisk3. You can enter your cholesterol measurements before you are taking your statin or off your statin and have a look. There are other particular scenarios where we might lean a little bit more towards a statin. The first is if you have bypass grafts, particularly vein grafts, and the second is if you have lots of stents, just because of the potential for you to develop the conventional coronary artery disease associated with those stents. It is an individualized decision, but that hopefully gives you a little bit of a vision as to some of those things. SCAD outside the heart. This is something that we've focused a bit on before in terms of the arteries, and we're interested in some things that are beyond the arteries now that we are looking to try and understand. Patients on the whole, the recommendation is that you have a brain to pelvis cross-sectional imaging scan by a CT or MR to look for these things. What I would say about head-to-hip scans and the arteries is that, again, the number of times that I will see something which is actually going to make a difference to the patient is small. FMD is common. Fibromuscular dysplasia, we'll hear some talks about that later on in the day. But FMD that actually causes a patient a problem is very uncommon in the context of SCAD. FMD outside the context of SCAD is a bit different, but it's worth understanding that's mostly asymptomatic. Sometimes you get a bit of pulsatile tinnitus, but actually then going on to cause a problem is uncommon. Aneurysms. We find aneurysms, we know that, but again, how important aneurysms are is related to their size. So if I send you a letter and say we found a small brain aneurysm that's, I don't know, 2.5 millimeters or whatever, don't get frightened by the word aneurysm, because it's all about the size. So we will talk to you about whether there's something you need to be worried or frightened about or not as part of the screening. But remember, when you screen, you find stuff. And actually the majority of the stuff that you find isn't frightening or worrying, and you don't need to be frightened or worried about it. There are some things which will change what we do. So sometimes we find dissections in other arteries in the body, not very often, but sometimes we do. In that case, we might well continue with your aspirin, for example. But, you know, it's those kind of tweaks. Most of the findings that we make here are not things that you need to be frightened about. They're things that we need to consider and weigh up. They may be things that we need to keep under surveillance to watch. Contraception, pregnancy and HRT. Again, this is something that we do a lot of talking about to our own medical community to try to improve understanding around this. In terms of pregnancy, it's important to understand there's a few key things. Heart function is important. So if there are issues with heart function and you're contemplating pregnancy, that's something that needs to be thought about. So often we will recommend that people that are contemplating pregnancy are referred to what's called the pregnancy heart team, which are the uber cardiologists who deal with this specific area, just to think about that, to make sure that you're on optimal medications, treatments and things, and to help you to understand your personalised risk if you have impaired heart function. The other thing that's important is that some heart medications are potentially damaging to an unborn baby. So again, if you are contemplating pregnancy, the recommendation is that before you take your folic acid, have a chat to your GP, and you may need to get referred on, or you may need to have some tweaks to the medications that you're taking. One of the commoner ones is ACE inhibitors, so ramipril is something that's not recommended in pregnancy. Statins generally also not recommended in pregnancy. So again, just get those things checked over. If you don't want to get pregnant, that's easy. Just make sure that you have adequate contraception in place if you need it. And if you need hormonal contraception, that should be progesterone-based. And then HRT is just worth kind of, again, just thinking about this. HRT gets a bad press in SCAD. Hormones get a bad press in SCAD sometimes as well. It's largely based around the fact that it's a female disease. And so people are worried that hormones must be the problem, and therefore that taking hormones must be a problem. But those things, again, don't necessarily follow. So, for example, SCAD is often a perimenopausal disease. So it's happening when the hormones are doing this or doing this. A postpartum disease after delivery of a baby, again, when the hormones are doing this, or a premenstrual disease sometimes. So it's more to do with, seems to be more to do with changes in hormones rather than the level of hormones that people are taking. To date, no studies convincingly shown harm or benefit of taking HRT in terms of the risk of SCAD recurrence, but we have to accept that data are not as complete as we would like them to be. So there's more to learn, and we hope that by doing proper research that we can bring to this, hopefully this conference in a few years' time, and we can say, well, okay, here's some data to back up what I'm saying. But at present, we don't see any signs of harm. Lots of you are taking HRT, and we don't see an association between that and recurrence. Our view at this time is that HRT is not contraindicated in SCAD patients who need it for intrusive menopausal symptoms and who have been adequately counselled as to the limitations of current knowledge, which you have just been. This is just a graph showing pregnancy-associated SCAD. You can see an example over here, just showing that it's predominantly after the delivery of a baby. It's a predominantly postpartum thing. And the other thing about pregnancy after SCAD, we talked a little bit about it, is the risk of SCAD occurring in a subsequent pregnancy. And this has been shown in 2 studies to be around 9%, 8 or 9%. Obviously, the risk of something more serious happening, like having a rhythm disturbance of the heart or having heart failure as a consequence of that, is much smaller than that 9%. But this is the risk. And the important message here, one of the important messages here, is that this risk can't be mitigated at the moment based on what we know. So it doesn't matter if you want to become pregnant, it doesn't matter how often I see you, I can't prevent something from happening that is spontaneous. Yeah? So we have to understand that risk and accept that risk. And then it's a personalised choice, in my view. So again, it's not that pregnancy is banned, and sometimes people will come to clinics saying they've been told that they can't become pregnant. Well, I think it's more of a choice thing. You have to weigh up those risks based on your own individualised risk that, again, you need to make sure that you have a discussion with, maybe with the SCAD clinic, maybe also with your local pregnancy heart team to make sure that you have that information. Post-SCAD chest pain. I won't ask for hands. So we all know that chest pain after SCAD, well, if you don't know, chest pain after SCAD is very common. It's almost universal, not quite maybe. There are some people who are fortunate and don't get very much pain. There are some people at the other end of the spectrum who do. Again, from the data that we've collected in the clinic, about 60% of patients are reporting chest pain at first follow-up. 40% of patients are experiencing chest pain at least weekly. Readmissions to hospital are common. On the whole, chest pain after SCAD improves over time in most patients, but there is a lot of variability. Some people will have more pain and it will continue over time. I sometimes say that sometimes it's a bit like the old war wound, so if you get a touch of COVID or a family bereavement or something, the chest pain is something that comes back. It's not angina. Just to explain this, angina is a chest pain which is essentially exertional. It happens when you're exerting yourself. So you'll be walking up a hill and you go, oh, I've got chest tightness, I need to stop and rest. Stop and rest, it goes away, and then you walk up the hill, get the chest pain again at roughly the same sort of distance. Post-SCAD chest pain is usually not exertional. It's more commonly at the end of a busier day, or if you have something stressful that happens. Sometimes if you're carrying or doing upper body exercises, that can sometimes make it worse in a few people. Obviously, one of the key things is working out what to react to and what not to react to. As often when you're in hospital with your SCAD, people will say, if you get any chest pain, go back to A&E. And obviously some patients who have a lot of post-SCAD chest pain are sitting thinking to themselves, well, maybe I need to pitch a tent just out. So it is a question of figuring out what to react to, and there are a few things that can help. First of all, it is a learning exercise. So if you go to hospital and you have a troponin check which is negative, basically that's not SCAD. Troponins are highly sensitive tests these days, and if your troponin is negative after recent chest pain, you are not having SCAD. And so what you can do is you can go home and reflect on that and go, okay, well, if I had that pain again, maybe that's the one I can be just a little bit more relaxed about. You know, try my bit of mindfulness exercise, try a bit of yoga or a cup of milk or a little stroll or a rest or whatever works for you to buy a bit of time to see if it goes away. The other thing is that when you have your heart attacks, it is a very variable thing in terms of symptoms, but often there are non-pain symptoms that can help you. Sweatiness, clamminess, nausea, or just feeling really unwell that there is something not right. Those things can also help with distinguishing post-SCAD chest pain because they can help you if they are absent and because you can think about it. So the journey through post-SCAD chest pain is not easy. And some people have very difficult experience with it. And we will try our best to help, think about medical strategies, but they are not easy because obviously the treatment that we use for chest pain is our anti-anginal medications. And they've already told you that this isn't angina. And so then it's not surprising, perhaps, that the anti-anginal medications aren't so effective. But there are still sometimes, I think, if we try different things, we can find things that help to some extent for people. And so, it's a tricky challenge. So, psychological impact. You're all here. So you are all making amazing progress after your SCADs and on your post-SCAD journeys. But we have to accept that having a major illness has an impact. And there is a normal grieving reaction after major illness. And this is quite normal. Sometimes we say that you're grieving for your former self, the self that you were before you had your SCAD. And I think probably the message here from me in the first instance is that this is normal. This is expected. And so don't be worried about it if you're tearful for a while after you have SCAD. It's normal. This is part of recovery and getting your head around what happens. Clearly with some people, that journey is longer, and some people will need some support through that journey. Some of the support that's provided, the peer support that's being provided by Beat SCAD, completely amazing, isn't it? Isn't that a fantastic thing for people to be able to access? Some people will also need professional help. In some parts of the country, rehab teams have access to counselling. Sadly, that's not universal. So it's worth asking your cardiac rehab professional whether they have access to counselling in case they do. If not, my recommendation is, because the waiting lists for counselling on the NHS are long, if you're having a tough time, then get on the waiting list. Maybe in a year's time, you'll have worked it through and it's okay. But if not, then at least you're not starting your place on the waiting list at that point. So it's something to think about and have that chat with your GP. I do get asked about emotional stress. There is a loose connection between emotional stress and SCAD. I think it's also important not to overstate this. There is a lot of emotional stress in the world, not a lot of SCAD is happening. Probably a bit of emotional stress, even in this room. And yet, SCADs are not happening every time people are stressed. It's not a one-to-one relationship like that. You know, this is why I think probably I've spoken to many people about this. We want to try and avoid what I call the stress-stress cycle, which is that you get stressed because that's part of life, yes? And then you're feeling stressed, and that's a bit worrying because stress is associated with SCAD in some way, and then all of a sudden you start getting stressed because you're feeling stressed, and then you get even more stressed, and then it sort of goes up like this. So this isn't helpful, really. And so I don't really focus on stress. If you can make small changes that reduce stress in your life, that makes sense. Make them over time. Generally speaking, if you have a significant illness, the thing to do at that moment is not to quit your job and move to Barbados, because probably that's going to be quite stressful. But if you want to make changes over time, have a think about those, but generally speaking, get back to the things that make you you, because that's the route to feeling better, and then make more planned adjustments if you think that that's going to help you. Clinical services. We need more capacity and we need to be funded. We do now have services. We have 2 services in London, one at Chelsea and Westminster, led by Dr. Al Husseini, and one at the Hammersmith, which I'm leading. We have a Scottish clinic at Forth Valley Royal Hospital, which is kind of working its way through and battling for funding to continue. Hopefully that will be successful. And we have the Leicester clinic. We are working hard with the Department of Health and NHS England to get the services funded. At the moment, it is a manic hobby for those of us that do it. And, it needs to move away from that. It's still a challenge, and it's a challenge that we manage to maintain because of some amazing people, some of whom are here and some are not. Jay is my medical secretary here. Probably quite a lot of people in this room will have had some sort of interaction with her. She is a completely, unbelievably amazing human being who keeps the whole service running. Because all of the times when, we need to get your MRI scan from South Wales, or we need to get an angiogram from somewhere in Northern Ireland, Jay is doing all of that chasing and answering all of your phone calls. And we've got Marie at the Hammersmith and Fiona in Forth Valley Royal Hospital who are doing the same equivalent role and learning fast. Both that running the SCAD clinic is really hard work for the support teams, but also that you're just such a fantastically lovely patient population to work for. And the clinical admin teams, again, people who are monitoring the SCAD emails. We do our best. If I've missed your emails, I'm sorry, but we're really trying hard to try and respond as quickly as we can. And of course, our clinicians, in addition to me, Abby and Claire, and we really want to expand this. I want a Manchester clinic and a Bristol clinic, and we're trying to work out how to fund that. We're talking to lots of people. In terms of referrals, this is probably mainly for the camera, because you've all been referred to somewhere, but this is how you do it. The important message for the camera is that we will take referrals from anybody. So it doesn't have to be a cardiologist. GP's fine, practice nurse is fine, rehab professional is fine. Anybody who sees a SCAD patient that they think would benefit from seeing the service, we will take your referral. There is a SCAD mailbox, which has become slightly unmemorably long since switching to nhs.net, but it's still there. We try to answer your emails. We apologise if we are not as quick as you would like us to be, and we are a small team, but we will continue to try and respond as much as we can and as quickly as we can. So the future is essentially about ongoing discussions with whoever we can try to persuade to fund the clinics. This is the Scottish Government in Scotland. So Swinny, we need your money to fund the Scottish SCAD clinic. NHS England as well, we need their money, and the British Heart Foundation, who have been increasingly supporting our research, which is fantastic. We're hoping that they might think about the clinical service. This again really for the camera. If you are a clinician and you want to know more and you don't want to get the diagnosis of SCAD wrong, read this, okay? And then for those in the room, looking after SCAD patients and making progress, which is what we all in the room want to do. We want to make progress in terms of managing SCAD patients. We want to be able to identify SCAD patients as quickly as we can, manage them correctly, prevent SCAD if we can identify people at risk, and obviously prevent recurrence if we can. This is about a partnership. I wouldn't be standing here if it wasn't for the amazing Beat SCAD trustees, and we would have no research if it wasn't for all of you signing up, giving bits of blood, bits of skin, going into scanners, doing exercise tests for us, all of these things. But what that means is that if I am able to stand up and deliver this talk in 10 years' time, that the slides will be different because we'll have different messages. We'll be able to answer some of those questions where I flannel a bit at the moment, and you think, he's flanneling. He doesn't know the answer to that question. I'll be able to give you some data to back up those questions and answers. So thanks to the Beat SCAD trustees, who are completely amazing people, superhuman people. Thanks to my team who have to put up with me. And thanks to you, because we can't do this without you. Thank you.
Thank you very much. If there's questions already, we've got the roving mics available. If anybody has a burning question.
Hi. So you mentioned that SCAD chest pain is not angina. So during a heart attack, a SCAD heart attack, is giving GTN life-saving, or will it not? Will it worsen? Because if the dissection is already happening.
Okay, so I need to clarify my statement, so thank you for helping me with that. At the time that SCAD is happening, and actually for a short period of time afterwards, the chest pain you are experiencing is due to a blood supply problem to the heart. So that is, if you like, an anginal chest pain at the time that you have SCAD. And one thing that's quite common, and it's something that we are trying to make medical teams aware of to tell patients about, is that because we are managing most patients conservatively now without stents, actually when people leave hospital, the narrowing, the bruise is often still there. It's got hopefully a little bit better, but it's often still there. And so sometimes patients will get true angina, exertional chest pain, for the first week, 10 days or so after the SCAD event. So that's important to recognise too, because it's expected. Because we haven't stented the narrowing, it's still there. But actually that bruise heals up pretty quickly to the point at which you can exercise without causing anginal chest pain. Post-SCAD chest pain is a sort of different phenomenon, if you like. It's very common, and it's not anginal. So we have done lots of scans where we've put people under stress while they've been in the MRI scanner who've had chest pain. And it essentially invariably shows that there is no blood supply issue. And so it's not, if you like, ischemic is the word, which means not enough blood getting to the heart muscle, despite the fact that they have lots of chest pain. So there are some distinctions from what's happening at the time. In terms of your question about GTN at the time that you have, somebody's having an event, GTN can help. It's a vasodilator. And again, because SCAD mostly causes narrowings rather than blockages of the artery, sometimes giving a GTN at the time can stretch the artery a little bit and can make the pain go away, and that can be helpful. Okay, so it's something that's worth trying. Always remember with GTN that it lowers your blood pressure. So if you are one of the patients whose blood pressure is already low, which will be a few of you, just bear that in mind. So if you take, you think, I got chest pain, 2 or 3 puffs of GT, yes? You're going to end up keeling over, yes? So if you need to use your GTN in that context, for the first time, if you've never used it before, be lying down flat. What you will tend to find with GTN spray for post-SCAD chest pain is, first of all, it doesn't work, and it causes you a stonking great headache. Again, it's something you can experiment with. There will be some people in the room who didn't mutter, and it does help you, and in which case it's fine. With post-SCAD chest pain, it's a journey of finding what works for you. And that can be, a range of things from medications to non-medication strategies. Yes? I talked a little bit about mindfulness strategies. Some people find those kind of things helpful because it's about what helps you to get, you through those symptoms to be able to live life.
Sorry, technical question. What about drug-coated balloons instead of stents?
So generally speaking, with interventions in SCAD, what we're trying to do is as little as possible. And I've emphasised already that sometimes we do have to put stents in and we do have to intervene in some patients. So trust the operator who's looking after you because they will usually make the right decisions here. In terms of different strategies, intervention strategies that have been tried, probably the one that's most in favour at the moment is something called a cutting balloon, which it's a bit like tears. It sounds a bit like, do I want a cutting balloon? But basically what a cutting balloon is, it just has a little scored edge on it. And what it helps to do is to just make a connection between the true and the false lumen. It makes a little hole between it. And what that does is it depressurizes the false lumen. And that means that things tend to stabilize. Once there's a connection between the true lumen and the false lumen, it's a much more stable context. And also if people then need to go on to stent, it doesn't tend to do the propagation thing because it's got a vent. So that as the stent expands, there's already a hole out of which the little blood that's in the false lumen can go. Drug-coated balloons are mainly designed to stop restenosis, to stop proliferation of the cells after balloon angioplasty has been undertaken. It's an option that can be considered, and people will sometimes do it if they're trying to do a procedure where they're only using ballooning. But often what I would advocate doing is using long, small caliber balloons to get blood flow back in the hope that you can then manage things conservatively without a stent. So I wouldn't necessarily be going down the route of trying to get a balloon angioplasty result, as you would do, for example, with atherosclerotic disease if you're treating it with a drug-coated balloon. So slightly technical thing. I think the main message here is pretty much to trust the teams that are looking after you, because the interventional cardiology community knows that they should be managing SCAD conservatively if they can, but they will also know that there are some SCAD situations which can't be managed in that way. So don't be frightened if in your case it ends up requiring stents, because sometimes that is needed. And so you just have to trust the teams that are looking after you because they are the pros, and my colleagues around the UK are pretty good at this.
There was a recent study about beta blockers on people with no or little damage after an event.
Yeah.
What are your thoughts on this?
Where are we at with that? Yes.
Yeah.
So there is growing data that beta blockers in conventional heart attacks are not helping patients who have normal heart function. And that's where the question arises from. But the emphasis here is that this is talking about normal heart attacks. In SCAD, the purpose of the beta blocker is usually slightly different, which is that we're using the beta blocker because of this observational study which suggested that beta blockers, independently of their blood pressure lowering effect, seem to be associated with a lower risk of recurrence. Now, we have to accept that this is observational data. So if you like, the gold standard is a clinical trial where I don't know whether you're on the medication or a placebo or not, and then we go through a journey together with the clinical trial medication, and then at the end of it, we get the data together, and I haven't managed to influence anything because I don't know what's going on. You haven't managed to influence anything because you don't know what's going on. And then we look at all the data, and then we can see what works and what hasn't. Now, there is a clinical trial of beta blockers that has completed recruitment, but included beta blockers versus no beta blockers in an open label design in Spain. It's completed recruitment. We would expect it to report within a couple of years. I know that they're analysing data and completing follow-up data now. So I think it's a good thing for people in the room to think about. Keep in touch with Beat SCAD. Keep having a little look at the website, because that's the place that we are going to post new stuff when it comes out. And you know that Beat SCAD, again, have been brilliant in funding little videos and little snapshots so that we can talk to, you put a little post up of the latest research data. So at the moment, on the basis of the observational data, which is the data we have, that is the basis of recommending beta blockers in SCAD patients to reduce the risk of recurrence from that observational study. But a clinical trial may supersede that data, and we are waiting for the findings of that study. And this is going to be the journey that we're on in SCAD for the next, decades. It will take time, because SCAD's not so common that we can get to the end of clinical trials in a couple of years. We have to take a long time to recruit enough patients to answer the questions. But those of us who are working with SCAD communities throughout the world, the Mayo Clinic in Vancouver in Canada, and many European countries as well in Australia, we're all determined to do this. It will be a slow road, but at the end of it, it will give us actual answers. So I can be able to say to you, beta blockers work, or they don't. At the moment, I can say there's some data to suggest that they might be helpful, and that's the reason we use them.
So we'll take one more.
Yeah.
I was just wondering if Beat SCAD and yourselves are talking to insurance companies, because a lot of the questions we get are geared up to normal heart attacks.
Yeah.
And we're asked, are we taking this medication for this purpose? Well,
Yeah.
we're taking it, but for a different purpose.
Yeah.
So are those discussions going on too?
So with insurance, the first thing to remember is that the raison d'etre of insurance companies is to wiggle out of paying out. Right? That's what they're there to do, because that's how they make their money. So if you do not put down on your insurance form something which the insurance company can then go, ha-ha, you didn't tick the I've got heart disease box, they will use that as a reason not to pay out if you need it. Yes? So when you're looking through the questions, you need to have a different threshold. This is not about what you think or what about something. This is what an insurance company is going to legally use to try and wiggle out of supporting you if you need support. So generally speaking, err on the side of ticking the box, even if that means that you have a little bit more, you have to spend a little bit more money in order to do that. So as I said earlier, common questions are, is SCAD a heart disease? Yes, it is. Is it a coronary artery disease? Yes, it is. Is it a heart attack? Yes, it is. Yeah. In terms of the medications that you are taking, it is reasonable if you are not taking your beta blocker because of a high blood pressure. Just because it's a blood pressure medication, if you're taking it for a different reason, it is reasonable to say that you are not taking a blood pressure medication because you are taking it for a different purpose. For the most part, remember that. In terms of conversations with insurance companies, I've not had conversations with them. I'm very happy to have conversations with them. I am extremely pleased that insurance companies are now specifically registering SCAD as something that they can put on their forms. And that's probably, I'm looking around at my trustee friends, probably only been happening for around about 4 years. Yeah. So that is a development. And I think it also, again, is a tribute to the trustees here and the efforts in terms of, getting SCAD out there into the world that insurance companies are now specifically insuring for this problem.